Good evening. My name is Karen Seidman. I am with Cuyahoga County Board of Health, and today we're going to again talk about people with access and functional needs. The goal, again, is to plan and operate emergency shelters and Point of Dispensing in Northeast Ohio responsive to the needs of all community members. Tonight we're going to have our first speaker will be from Red Cross, and so we hope that you will be able to describe the Red Cross vision for the accommodation of people with functional and access needs in emergency shelters at the end of that presentation. And then we are going to have our second presenter will be from Mental Health Services, and so we hope that at the end of that you will be able to identify at least 3 roles or approaches a shelter worker or a pod worker can use when working with clients with mental health illness. So we are ready for our first presenter, and it's Megan Koethe from Red Cross, and she said that she would introduce herself. So I will let you do that, Megan.
Hi, I'm Megan Koethe. I'm a disaster response specialist with the American Red Cross Greater Cleveland chapter. I cover Cuyahoga County. As you may know or may not, we just recently visualized as part of a national effort, and the Red Cross of Northeast Ohio consists of 22 counties, and I think it's now 14 chapters. So I, again, am part of the Greater Cleveland chapter, and I cover Cuyahoga. But so a little bit about my background. I have a master's in Homeland Security from Penn State, and I concentrated on public health preparedness and planning, and master's of public administration from Cleveland State. The reason why I talk a lot about functional needs is because it's my access to public health at work. So I've been lucky enough to have the responsibility to help several of the counties in our region with functional needs planning. This presentation is a little lengthy. I didn't quite realize how long it was, so if you have any questions at any point, just feel free to ask them. And if I forget to say next slide, please let me know because I have a feeling I'm going to. I decided to talk a little bit about my presentation is going to be about sheltering and how we now are having a functional and access needs populations in our general population shelters. And so that's not how it used to be. We used to have special needs shelters. And that the Red Cross is mandated under the Emergency Support Function 6 to shelter the population in times of disaster and need. Just to kind of give you a little bit of a background. Okay, so next slide. So today I'm just going to review a couple of our current philosophies and guidance around functional needs support services. And we're going to look at the functional needs support services in a shelter environment. And if you're not familiar with the shelter environment, kind of give you an idea of what it's like and how we used to have it and what we're trying to move towards. And we're going to talk about how the Red Cross chapters around the country are trying to focus on integrated community planning. Oh, and if I talk too fast, just let me know. All right, so our planning for functional and access needs populations in our shelters are based around these ADA guiding principles, which include inclusion, integration, equal access, self-determination, physical access, reasonable modifications to policies, practices, and procedures, and effective communication. Okay, so to accommodate individuals with functional needs or functional and access needs in our general population shelters, we are working to make reasonable accommodations to our policies and practices, and also acquire assistive technologies such as durable medical equipment like wheelchairs, nebulizers, and canes, and then also have a small stockpile of consumable medical supplies, such as things that are ingested and used only once, personal assistive services, and other goods and services that may help our clients so that we can accommodate them in our general population shelter. And we also try to remind all of our shelter workers, they kind of freak out when we talk about taking in functional and access needs populations in our shelters, that when our clients are coming from their homes, they're going to know how to take care of themselves best, and they're going to usually be able to bring the items that they need to take care of themselves, so we won't have to have a large stockpile. So that's why we say a limited stockpile. Okay, so since this isn't the first functional needs presentation, you know that people requiring functional needs support services are individuals that may have physical, sensory, mental health, and cognitive and/or intellectual disabilities that affect their ability to function independently without assistance. So these are the needs that we must address and be aware of when we're working in a shelter, is make sure that we are giving equal access to communication, like messages about the disaster or what's going on in the shelter, medical and health needs, allowing independence of our shelter residents, safety and supervision, transportation, and behavioral health and mobility. So the functional and access needs include, this is not meant to be a complete list, but It's a way for us to help start to think of how to plan and what to do with the population. And we have to think about who in our community meets these or fall into these groups and what groups and organizations can help us with planning. So this is what the Red Cross is currently doing. We started to think about the different activities that occur in a shelter and what we need to do to make sure that individuals with functional and access needs can still do these, such as eating, bathing, grooming, dressing, communicating with shelter workers, sleeping, so we had to work on getting large cots or functional needs cots, taking medications on time, and orientation to the date time. So we always write on the walls of our shelters, this is something little but can be very helpful, is what date it is, what time it is, or we have always have a clock with a date and where they are. Because in a disaster, people may become disoriented, especially individuals with dementia and other mental health and cognitive issues. Okay, so these next couple slides are just some of the conditions that may affect mobility. So these the frail elderly, people with Parkinson's diseases, and morbidly obese. Next slide. Individuals with temporary physical limitations, like people that just had surgery or pregnant or just broken bone that are in casts. Sensory and communication challenges, such as speech disabilities, language and cultural differences, and literacy. And this is something that I know our DAP volunteers and our shelter volunteers are usually very familiar with because we see clients weekly. Like I just yesterday had a client who didn't speak any English and had to remember my Spanish from college and, translate everything for her so that we could still give her the same assistance that we give someone that does know English. Cognitive, intellectual, and cognitive and mental health disorders, so people with dementia or autism, and I know we really heavily rely on our disaster mental health volunteers, and just for those of you that don't know, all of our disaster mental health volunteers are licensed social workers or psychologists. Chronic but stable conditions, these are things that people we're so used to helping people with fire, so these are things that we deal with daily, like asthma, allergies, so now we just have to think of ways to handle this in a shelter. And one thing that I know that we're definitely looking at currently is our food, and making sure that we do have a nut-free environment if we need to be, or making sure our snacks some are gluten-free, we have some gluten-free, some nut-free, some that are okay for diabetics. And I know that when we do canteen for the fire department, it's brought to our attention that we always provide sausage sandwiches for the breakfast, so even religious considerations for our clients. Next slide. Okay, so here's just a little bit of information on the functional needs support services in our Red Cross shelters. Okay, so the Red Cross commitment is to work to ensure accessibility. So when we say accessibility, we don't mean compliance, because the Red Cross is not a regulatory agency, and we cannot ensure compliance because most of our shelters are held at facilities that we don't actually own. So what we do try to, when we go out to perform our shelter surveys, is to make sure that they can be either gate accessible or they have at least like one accessible entrance, one accessible bathroom, so that people with mobility issues can still use our shelters. Okay, so the Red Cross sheltering philosophy is that shelters must receive places of comfort and safety. They must be readily accessible to those affected. Shelter workers must be strong advocates for our clients, so they have to become familiar and know what signs to look for, and that's what's really important about these lectures and seminars, because it kind of teaches our volunteers that aren't necessarily social workers or nurses on how to look for those signs in the population to give them further assistance. And then clients must remain proactive participants in the recovery, so we say that all the time daily with our fire clients. They must be a part of the process, so we can't always continually follow up with them. They need to take the process into their own hands. So that would be the same in a shelter for those that can. Shelters must be able to provide a safe and secure environment that accommodates the broadest range of needs in our community. So we always ask both our staff and volunteers, would you be comfortable with your mother, like grandfather, brothers, sisters, or children living in the shelter? Sure, there's a question.
I'm Danielle LaFarge. When on a test that was active participants in recovery, but what if they have dementia or something else and they just can't do that? That's why I put like thoughts on there.
So that's when they are able to be proactive in their recovery. So that's where we need to look at certain signs, and that's what we're teaching our volunteers on, how to know if someone with dementia, because what we do, I talk about a little further in the presentation, they have a screening process for when we do registration for our volunteers, or for the residents of the shelter. So we can kind of figure out in the beginning if they, and identify if they do have any functional access needs, so that the shelter workers can keep an eye on them or provide the additional services. So definitely for someone with dementia, they wouldn't be able to be active. So that's where our volunteers definitely need to learn how to accommodate those individuals and look for those signs. Because even if they don't say in the beginning that they do have dementia, we need to be able to identify it so that we make sure that they get equal accommodations. Does that answer your question? Oh, and the question was, what about people with dementia and providing, if they're proactive participants in the recovery? Right. Is that answered or no?
Well, I don't know if it answers what the test question was, because I feel like contradicting what we're saying, that they must be active.
Yeah.
But if they can't be, they're not going to be proactive.
Right. Well, that's where the shelter workers need to be the strong advocates of the clients in the shelter.
Then that should be changed to should be active, not must.
Yeah.
Okay.
Because that's what we were having a problem with, trying to decide that answer.
All right. Well, then I apologize. I will
okay.
take your note and change it. Okay. Next slide. So some of the common issues. Most disabilities are functional in nature, meaning that providing accommodation support in the area of supervision, transportation, or communication will allow them to remain able to manage day-to-day living in a shelter. So those are the kind of things that we look for. So they're seen and treated as medical issues rather than functional needs. Access issues are seen as a challenge rather than opportunities. Local assets for support are either unknown or have not been contacted involved prior to the disaster. So it's really important. That's what we're doing now, trying to reach out to groups and organizations that might be able to assist us and identify those populations. And Americans with Disability Act is not well understood or operation in some communities. So for our shelter planning, we are trying to think broadly when planning for shelter accessibility. We have a new shelter survey, which I've become very familiar with. We are trying to look at all of our shelters around our region, and it now has an accessibility assessment in it, and it kind of gives us 3 options. We need major changes to make the shelter accessible, we need few changes, or is accessible. So that kind of allows us, when we're going to open a shelter, and all the emergency management agencies have the copies of our shelter surveys, they can identify what shelters would be accessible. And especially if it's in an area where you know that people with functional access needs are going to need a shelter, then you would know that you need to find a shelter that is accessible for that population. So this is kind of like what I just talked about, what the survey addresses. So the relevant areas of the facility that are accessible to people with disabilities without adjustments. So we also try to look for if there's at least one entrance and a restroom, or is able to be, like sometimes it just needs a ramp or maybe a toilet seat riser, something as simple as that. There's access changes, so we wouldn't necessarily use it if we knew there'd be a large functional and access needs population requiring shelter. By applying these 2 ADA basic principles, it allows us to keep the family and friends together, so that if one person of the household does have a functional access need, they can still be with their family. Because prior to this, they weren't able to because they were going to a special needs shelter. So now everyone can be together, and that'll also help with the recovery and also for mental support. It also allows us to ensure equal and standardized service to all of our residents, no matter what their needs are. So by applying these basic principles, we're also working with different EMAs and other nonprofits to make our shelters accessible. So like in Lake County, that's where I used to work in Lake County for the functional needs planning. And one important thing that we did is we identified all of the shelters that would need some adjustments and what the common things were. And I'm sure this is the same in almost every county in their shelters, is that the need for functional needs cots, toilet seat risers, and like large signs so that we could change things in ramps. So those are the things that we're trying to work on procuring for each county. So functional needs cots and toilet seat risers, they do have like a cost of, and so there's ramps, but so we're just working on getting grants and working to see if there's anyone in the community that could donate these items that we could use them in a time of disaster at our shelter to make them accessible. So some simple little changes that we can make to our shelter layout can really help people with functional and access needs allow for more mobility around the shelter. So a shelter layout, we currently look at, in a shelter, allowing each shelter resident up to 20 to 40 square feet, so that's how we figure out the population that's going to be in the shelter. And it's depending on whether it's before the disaster happens or after. And so now we can allow for people that have mobility devices like wheelchairs, we can give them up to 100 square feet. So we'll just know based on that population in the area, unless we can determine that, like, should we allow for more space for people with wheelchairs that would be likely to shelter. So this is just an example of our intake tool. So what happens when you go to a shelter, you arrive at the shelter, you start to fill out your registration form. Our regular staffing volunteers, they will fill out the registration form. So these first 9 questions they'll ask, and depending on your answer or the shelter resident's answer, will determine whether they need to go see someone that's a disaster mental health volunteer or disaster health services volunteer. So then, this is how we will determine if they have any of those. These are basic identifiers that we can determine. If they do say, depending on the answer, if they do qualify for that, then we would send them to our disaster mental health or our disaster health services volunteers. We're in a shelter that's also really MRC volunteers would be helping us out. So we send to that, and they would further ask them our questions to try to determine if there are any needs, and if they need to stay, if they can stay in our shelters, or if they need to be referred somewhere else to a hospital, for example. There's a question.
Can you read those names? Because they're unreadable on our sheet.
Okay. I have really bad eyes. Oh, I can see here. Do you need assistance hearing me? The second question is, will you need assistance with understanding or answering these questions? Do you have a medical or health concern or need right now? Then the observation of the interviewer, does the client appear to be overwhelmed, disoriented, agitated, or a threat to self or others? Do you need medicine, equipment, or electricity to operate medical equipment or other items for daily living? Do you normally need a caregiver, personal assistant, or a service animal? Is your caregiver, personal assistant, or service animal inaccessible? Do you have any severe environmental, food, or medication allergies? And then the last question is a question to the interviewer. Would this person benefit from a more detailed health or mental health assessment? Okay, so this is, I kind of explained this in the last one. So in a large disaster, we would need mental health or MRC volunteers to back up our current existing mental health and health service volunteers to help screen them with this. So we would use both health services and disaster mental health at the time of registration, and work directly with the clients to determine the next steps and accommodations would be needed. So the assessment definitely continues beyond registration. So we talked about people that may not be able to identify in those first 9 questions if they do have a need in the beginning, and then they may just develop it as the situation goes on. Or I know for some individuals with dementia, they do have sundowning. So in the beginning of the day, they may be very aware of what's going on. At the end of the day, they may need further assistance. So this is the kind of thing we're trying to train our shelter workers on, being able to identify those needs. Here's just another few modifications that we're making, or these are easy modifications that can be made, is the shelter operations to assist with those that have functional access needs in the population. So we could just modify kitchen access for people, assist with cutting food, provide ways of finding assistance to visually impaired, effective communication. That's a big thing for everybody in our shelter, so this might help us get better at it. Offer individual Safe and Well registration. So if you don't know, Safe and Well is a website that we have in large-scale incidents. It's so the clients come in when they register, and they can put their name into the system, and then anyone in the world can check from the website if their family member is safe and well, as long as they know their address and phone number. So we can help people input that information that aren't able to do that. And we can assist client caseworkers to ensure clients return to the most appropriate, least restrictive environment when the shelter closes. So we're not going to close the shelter until every last individual has a place to go. And that includes our functional and access needs populations, where they may even require more work to get them back to their normal environment. So a new part we have in all of our shelter trailers, which we have shelter trailers staged around the whole region and all the different counties. They have this communication tool, which is in 13 languages and Braille, and we also have a couple for sign language. And what they do is they just ask all the basic registration questions in those languages. And it also, there's an initial site that allows us to see, so we can see what language they need. And those are just that's the 13 languages right there.
Is it electronic?
No, we have them laminated. Okay, so service animals. This is a big one, and I know that we're working in many counties to work on this. So the first thing is that the Red Cross, when someone comes with an animal, we don't know if it's a service animal or not, we are only allowed to ask 2 questions. And that is the service animal required because of a disability? And what work or task has the animal been trained to perform? Now, we don't have the same guidelines for service animals like the Department of Justice has. They have it where it's only a dog. We allow any service animal, it could be a monkey, it could be a bird, it could be anything, as long as they can qualify under those 2 questions. We do not allow therapy dogs or companion pet, or therapy animals or companion pets in our shelters. It is the owner's responsibility for their pets while they're in shelter, but we can provide food, water, help with waste disposal, stuff like that. We do have some leashes, bowls, items that the animals may need. So this is an issue that we face in some of our counties is we have a limited number of disaster mental health or health service volunteers. And obviously, when you're opening shelter, you're going to need these volunteers right away to help start screening the population. So we can, so when we do have a limited number of health services and mental health service volunteers, we can do it over the phone. We can reach out to mental health services and agencies in the community and public health, and we can reach out to our other regional chapters and our national headquarters. So these are just a couple of suggestions for mental health, and we normally, this presentation I've kind of modified a little bit for today, but this is what we would show to our mental health volunteers, but since I know we have some mental health and MRC volunteers in the audience, I thought that this is some pointers that our national headquarters got just from previous disasters, that these are things that people need to remember. Let the conversation with the individual guide you and not assume about mental illness. Keep your communication simple, clear, and brief. And if someone is confused, don't ask multiple questions. Ask or state one thing at a time. And then this would be for anyone, CERT volunteers, MRC volunteers, Red Cross volunteers that are working in shelter. These are just some suggestions for people, shelter residents that have cognitive or intellectual disabilities. So we want to try to reduce the outside distractions when communicating. So I know that when I completed a shelter survey, I like to look for extra rooms that are around the sleeping area, classrooms, because usually in schools, that we could put children with autism or individuals that would need the quiet when they're in the shelter. We need to concentrate and use open-ended questions and avoid yes and no answers, and allow for additional time for two-way communication, allow time for information to be fully understood, and avoid complex terms and use shorter, distinct terms. So when might a shelter client need to be referred to a medical need shelter, hospital, or other medical setting? And instead of offering that off to the group, it's just that the Red Cross can only accommodate, and there's certain things that we have to look at. Do they need a reliable electrical supply? Because a lot of our shelters don't have emergency generators, so if they do need that reliable electrical supply, we may need to transfer them to a hospital or another shelter. If the situation changes, like if a woman goes into labor, they obviously need to be transported. Other things that we might not be able to accommodate and might be better accommodated other places are like home dialysis, recent surgeries that require constant supervision, and some significant health issues who's not comfortable remaining in a general population shelter. So at the end of the day, it's up to the residents to decide, or the clients to decide whether or not they want to stay in a general population shelter or not. So these are just other considerations for referrals. So individuals who need medical supervision, acute life-sustaining medical care, and individuals who are in danger to themselves or others. So integrated community planning. So this is what we're trying to do, reach out to the different counties around our region to start the planning process for this. So in 2010, FEMA provided guidance that shelters must now allow functional access needs populations in the general population shelters. But this guidance does not establish a new legal obligation. Instead, it is a guide to integrating service delivery to general population shelters. So this is a process that we're currently doing across the region. So we're trying to take a look at what our current plans are, identifying the stakeholders that we need to reach out to. Like I called pet supply stores to see if we could get different supplies in an emergency for our shelter residents, or even for our clients on our daily fire calls. That's just an example of a stakeholder we can reach out to. Community gap analysis, we need to reach out to different agencies who serve these populations and try to get an idea of how many people are in the communication, or if there are little pockets in the community that may have these needs. So when we shelter, we know that the shelter may have a lot of individuals with functional access needs. And identify the resources and establish relationships that we already have and what we could have. So these are just some of the different stakeholders. So obviously government, emergency management agencies, public health, family services, area agencies and councils on aging, centers for independent living, providers of transportation, that's something big, and these other resources that we might need, and MRC. And here's some more. State-based organizations, and we do have different national MOUs with different groups. An example is the National Disability Rights Network, so we can reach out to them for information and resources in time of a disaster. So again, like I said before, we're working with different groups to identify the types of disabilities in the community and where the pockets are. Oh, so what we're currently doing is we're trying to get the resources that we need and establish those relationships. And our national headquarters is establishing a chapter suggested list of what they're learning from different disasters around the country. So I'm sure we'll get a different list from Hurricane Isaac of things that were needed and different steps that were taken. So it's kind of nice having those resources so you can see around the country what arose. So if that community is similar to ours, then we'll know that we'll need those items probably too. So this is just a little bit on the lessons learned from 2011 that we found out from our headquarters. So just in 2011, we saw floods, tornadoes, wildfires, and we know that these are going to keep continuing. And so from the Alabama tornadoes, there were over 23,000 units or like homes and businesses that were affected. We had 35 shelters open with over 7,900 overnight stays. Just think about how long those shelters were open. And we had, when it says greater than 16,000 mental health contacts and greater than 10,000 or mental health contacts and 16,000 health contacts, that means that our clients receive mental health or health service assistance from our volunteers in the shelters. So that's just an idea of what a large scale incident, what would be required. So what happened following the Alabama tornadoes is that a group, which was the Alabama Interagency Coordinating Committee, was established, which was 60 members from state and nonprofit agencies who serve people with disabilities and chronic illnesses, individual advocates, university faculty and students, and there was the FEMA and Red Cross participated too, and it was formed just 2 days after the tornadoes happened. So this is something that, so what they did just to meet the functional and access needs populations that their needs were following the tornadoes. This group met to see what resources they could pull. They had daily conference calls to talk about the community as well as individual client needs. So if there was something that was out of the ordinary or that someone had never faced before, they could talk about it and see if there was anyone on that call that could assist with it. Support for local clients with disabilities and reunification of family and support agencies. So if a client is taken away from where they're used to and they are reliant on having their oxygen delivered, we need to figure out how to get them that oxygen after the disaster happens. Provisions for personal assistance services, placement of ASL interpreters in shelters. That's something that we are finding that we do need more sign language interpreters, because usually with foreign languages we can kind of figure something out, but the sign language is something that's definitely something that we need, and here in Cuyahoga County. And identification of long-term recovery programs. Okay, so what they learned was that the coordination team needs to be activated as soon as possible, and so we need to know who to call upon to see to get those resources, to get those needs, to meet and accommodate those with functional access needs that are coming to the shelters. Ways to close the loop specific so that we know that the clients in this shelter got what they needed. Resource lists that are local, regional, and statewide, and coordination between Red Cross and FEMA disability integration specialists. So that's some of the things that they learned from the Alabama tornadoes. So some of the key considerations for when planning for Red Cross or for sheltering functional needs populations and general population shelters are just planning and responding with key partners. Functional needs support service guidance does not require stockpiling services, but the ability to secure those resources when we need them. Understand ADA principles and how to apply them. Be aware of functional needs support services at all levels in our chapter, so that it'd be like in our community. And then these are some of the things that we're working on now. Is we have nursing kits for each shelter that are stockpiled with appropriate size. So we kind of went back and looked at our kits and see what we needed to add to it. Exercise and evaluate your integrated community plans with real people, and anticipate client needs with your community focus on accessibility and planning. And I'm just going to add in the presentation. I know there's a couple extra slides. So is there any questions?
Cuyahoga County.
We missed what the letters VOAD and COAD stand for. Could you run that by us again?
I was going to ask the same question.
Oh, that's Volunteer Organizations Active in Disaster, and it's Community Organizations Active in Disaster. So that's COAD and BOAD.
Right. Okay, thank you very much.
Okay, great.
Questions from Cuyahoga County? George.
Yes. I just want to ask, doing a disaster and you have shelters set up, do you have a limit date for the amount of days your volunteers can serve?
So the question was, how long can a volunteer serve?
Yeah.
in a specific shelter?
Okay, well, so our volunteers act in 12-hour shifts, so you would be working for 12 hours most likely in our shelters. If it's a large-scale disaster, we actually recruit our volunteers from our regions around the country, and it's from our disaster services human resource system and DSHR. So they are actually asked to deploy for 3 weeks. So we actually sent down 33 volunteers from Northeast Ohio to Hurricane Isaac to do a variety of things, some of which were sheltering. So they're always asked to do between 14 and 21 days deployment.
14 and 21 days.
So locally, when we call on CERT or MRC, it would just be based on your availability.
The reason I ask that is I've done volunteer with the shelters for Red Cross, and one of the things that used to take place is we were always checked out by the mental health nurses, and if they thought you needed to leave, they would ask you to leave.
Yes, all of our volunteers are for sheltering, for like fatalities. We always have our we do have mental health volunteers follow up with our volunteers to make sure that they're handling the situation okay. And we just had, I think, maybe 5 people come back this week from Louisiana, and our mental health volunteers will follow up with them within 24 hours of coming back to make sure that, you know, they're handling the situation okay, what they need to talk about. And the same, like on a regular fire call, we do that for fatalities. So even staff we get a call from mental health to make sure that we're doing okay.
We are going to now have some people from our ADAMHS board, our local ADAMHS board, and from mental health services, and they will introduce themselves.
Good evening. My name is Ashland. I work at the Alcohol, Drug Addiction, and Mental Health Services Board of Cuyahoga County, and the board does not provide services, but we contract with mental health and alcohol and drug addiction agencies to provide services, and then we plan for the services we want them to offer, and we fund them for those services, and we monitor those services. One of the agencies we contract with is Mental Health Services, and some of the services that Mental Health Services provides are crisis services for all Cuyahoga County, as well as services for the homeless persons who are also severely mentally ill. And we have with us today Latonya Murray, and she is from Mental Health Services, and she will come and introduce herself to you.
Hello, everyone. I'm Latonya Murray, and I'm from Mental Health Services. We're commonly referred to as MHS because we provide a lot of array of services. We have a crisis arm and a homeless services arm. So for our crisis services, we contract with the ADAMHS board, and we provide mobile crisis services to individuals experiencing a mental health crisis in the Cuyahoga County, and we also operate the suicide prevention hotline for the area. And we're nationally recognized, and we're part of the national network for suicide prevention hotline services. And on our homeless side, we provide an array of services from outreach to individuals who are on the street all the way to permanent supportive housing. So we do outreach, we do shelter services, we provide case management and linkage services, as well as permanent supportive housing. But I'm here today to talk about what we do in our emergency shelter and working with, and to provide you with an overview of mental illness. I've been with MHS for over 20 years, and I've done a whole lot of things at the agency, including working in our shelter, outreach and case management. I oversaw our quality improvement programs, done a lot of training for our agency, so I was glad when Esme asked me to come and speak today. So as I indicated, I'm just give you an overview of mental illness, and basically mental illness is biologically based brain disorders, and it responds very well to medication, and symptoms often come and go. One thing is very difficult, or often difficult, to actually diagnose and treat correctly. You have to get to know the person, so even a trained psychiatrist kind of has to get to know the patient, the person in front of them, get a long history, and you might present one way today, and then next week when your crisis is over, it depends, you're a little calmer, and then they can solidify the diagnosis. So sometimes it takes really getting to know individuals before the proper diagnosis is established. There are there's several classifications of mental illness, but I'm just presenting you with the common classifications, and I'm going to discuss psychotic disorders, primarily schizophrenia, that's the most common. We're going to discuss mood disorders, major depression and bipolar disorder, anxiety disorders, post-traumatic stress disorder, which people probably will see and experience in an emergency shelter following a natural disaster. That would be very common. I'm not going to talk about personality disorders or substance abuse disorders because those are really long-term, more disorders that take a substantial treatment and counseling. So I'm just giving you an overview of probably the top 3 or 4 diagnoses. So with schizophrenia, some of the symptoms are listed in front of you. When most people think of individuals who are schizophrenic, they picture the person who is in a corner somewhere talking to themselves. That's because the most common symptom of schizophrenia is hallucination, and hearing voices, auditory hallucinations are the most common that we find. And the other symptom of schizophrenia are delusions, which are fixed, false beliefs. So it would be relevant to paranoia or grandiosity. Someone may feel persecuted at all times, or it might be someone who thinks they own the Taj Mahal. So that would be grandiosity. But these hallucinations and delusions are very, very real to the person experiencing them, and that affects how they interact in society. That affects how they behave daily. And so medications are very helpful with schizophrenia with this. But in that case, too, it's still the right medication to diagnose. Other symptoms that you would see would be disorganized speech, someone talking about everything, or poverty of speech, they're unable to talk. They really can't get their thoughts together. Disorganized behavior, it may start one thing, can't finish, jump to the next thing. Abnormal emotions, they're upset today, and they shouldn't be, or they're happy, and you think, they just lost their home or something in a disaster. So it might be some things like that. Social withdrawal, they isolate, they don't want to talk to anyone. And there may be cognitive problems, may have trouble concentration, attention, problem solving, and just lack motivation. So those are some common symptoms with schizophrenia. So how should the worker respond to this? With a psychotic belief, if it's a delusion, the worker should just accept that psychotic beliefs are real and should just talk with individuals about their beliefs in a real manner. Once upon a time, I had a client who believed she wasn't paying her rent because she owned the building, so she didn't have to pay her rent. So sooner or later, I said, well, I need you to work out something with these people so that you can stay here, because that's what is evicting you, and I need to help you with your money. So finally, she agreed to work out, the mortgage payment for her building and pay taxes, and eventually with medication, I was able to get her to accept the fact that this was not her building, and she didn't own it. She was spending all her money redecorating, major redecorating, buying new tubs for her apartment. So those when I say, accept that they're real and work with people where they are. So we have to provide concrete needs, empathize with feelings. So, I was understanding, I was patient with her. So those are the things, exhibit patience with disorganized behaviors. So we really have to show patience. And maybe in this disaster situation where they're finding themselves in an emergency shelter because they've lost their home, we may have to think about separating them. So separate someone because they are anxious. So So just to diminish their anxiety, it might be important to just move them to a different area within the shelter. In our emergency shelter, we find that to be helpful oftentimes. We have larger dormitory areas, and we have smaller rooms. And so we try to save smaller rooms for individuals with these special needs who might be a little anxious in crowds. We have to be patient. We have some ladies who won't even sleep in a bed. So if that's the case, we'll let you sit in the corner on your suitcase. You know, we just have to show a lot of patience with behaviors until they become comfortable with the surroundings. The next one I wanted to talk about was mood disorder, which the first one is major depression. So symptoms of major depression should last at least 2 weeks, and most often is much longer, but at least a minimum of 2 weeks in order to give a proper diagnosis of major depression. And depending on the disaster situation, I'm not sure if you all will see this, but I thought it was relevant to talk about today. Some symptoms would be sadness, just overall sadness, inability to experience pleasure, real doom and gloom. Change in weight, maybe an increase in weight because now you're depressed, you want to eat everything, or a decrease in weight because you don't want to eat anything at all. So it depends on the individual. Change in sleep, same thing. Some people sleep all the time. Some people have insomnia. So there's differences. But these things together are the things that we have to pay attention to and determine whether a person may be depressed. Also, feelings of worthlessness or excessive guilt. They have a lessened ability to think or concentrate. So just can't focus, can't make decisions. They have no feelings of hope. And they may have recurrent thoughts of death or suicide. When people are diagnosed with prescribed medication for depression, these symptoms are often taken into account with the doctors in terms of which medications are best to assist them. So some medications help people sleep. Some people's medications will give them a little more energy so they're not sleeping as much. But medications often take a while to work. But these are just some things that you all may see if you were to see someone who was depressed. The worker's response, the worker's role. If you have the mental health disaster workers on site, it would be best to alert them and inform them of the situation. If there's concern about maybe suicide, ask people specific questions about whether they are feeling at risk of harming themselves. Are you thinking of hurting yourself? Do you have access to weapons? Those are the things that we do. Can we develop a safety plan? How can you keep yourself safe today until I get you to the proper person to talk to? Those are the things that we typically do for suicide prevention. We don't necessarily try to cheer somebody up, tell them, everything is going to be better unless you can concretely say, this will happen. This will be a different situation. So you want to give them concrete encouragement if it will be so. Offer support and realistic hope. So give them real concrete things for encouragement. So you have to be able to provide something. And the best thing to do is get them to appropriate staff. Bipolar disorder is another mood disorder, and the major symptoms of bipolar disorder are fluctuation between mania and depression. So you will sometimes see people on very high, always moving, can't sit still, can't function, can't concentrate, always on the go. Oftentimes people who are experiencing mania are on spending sprees or doing things that are not what we would consider normal for them, maybe thrill-seeking, things of that nature. And then at other times when they're cycling down, they're depressed, so they're experiencing lows. So that's where you have a fluctuation between the two things, which is why I say sometimes with diagnosis it takes a while to really understand where the person is. And your response to them depends on where the person is in the cycle. So if they're depressed, you treat them as such. I think I wanted to make sure we talked about post-traumatic stress disorder because you will find this as after a natural disaster for many people. the major thing of post-traumatic stress disorder is a cluster, the definition of the cluster of symptoms that develop as a response to an extreme trauma. And trauma can be different things to different people. So examples of trauma that we see commonly in a mental health field are sexual and physical abuse or domestic violence, homelessness, death of a loved one, but a natural disaster would be more common for you all, what you would see, I would assume. Other symptoms that people see are nightmares. They experience nightmares, can't rest. As soon as they go to sleep, they're reliving what has occurred. They may have these flashbacks even when they're not sleeping. They can't think about anything but that traumatic event. They have extreme anxiety. Yes, some people have feelings of detachment. They've learned to protect themselves from whatever harm they felt before by becoming more detached, by isolating themselves, being a little cold or standoffish, being guarded in their responses. Or you might see people who are having outbursts of anger. They're just defending themselves. There's no real reason for them to be angry, but they feel the need to defend themselves. And then there's hypervigilance. They're always trying to make things right. Always they're doing something, just focus on the task. So there are different things for different people. In this instance, we would do have the same thing. If you have appropriate staff, you have a mental health disaster trained worker on site, then that's who you would contact as soon as possible. You would make sure you listen with empathy to the person, and they're telling their story, but don't try to make them bring up old things or relive bad experiences, but also don't minimize their feelings, know that they're real, and just provide them support. And understand that trauma survivors may seek ways to feel in control of the situation. So including blaming others for what has happened or what's going on right now in the moment. So I don't know, maybe in a fire, if such and such hadn't done this, I would still be in my home, and this is terrible. And so they just have to feel in control. And in all instances, seek support to get someone else to assist this person, especially someone who's mental health trained. And because sometimes just the interaction with that individual who's experiencing PTSD can be so traumatized and so straining and stressful for you, you may, as a worker, need to get some support. So just as was stated earlier, when people are going and to assist during these natural disasters, they've always been checked out by a mental health specialist at the end of their time there. That's one major reason why people do have to have support. I listed resources here for everyone. Our ADAMHS board, which as mentioned, is Monday through Friday, and they have all the resources because they contract with everyone. And then I listed our agency's mobile crisis team because we're there. We're available 24 hours a day, 7 days a week. And as I said, we will come out and assess situations. It's just people experiencing. All the staff in the mobile crisis team were trained by the Red Cross, and so they know the mental health disaster. They've done that training, so they know that expectation. We also, as I said, we do suicide prevention for the county, and we've called upon a lot in a lot of situations to assist. We have a violence loss response team, so we're called upon by the police because we assist with that. We have our Children Who Witness Violence program. These are funded by the Department of Justice, and so when children are witnessing abusive situations or other violent acts, we provide assistance with them, crisis services, as well as counseling. So our agency is out and about a lot. Are there any questions?
You mentioned suicide. How do you approach somebody to ask if they, you sort of give some ideas. Do people answer truthfully? or are there some people that even if you ask them, they may deny that they have those spots?
And it depends on, I think like you said, sometimes people are truthful about it, oftentimes people are not. But we do just, you approach them, just you seem a little down or you seem depressed. You don't want to leave them, but you do want to ask, I'm concerned, I'm here to provide you with some support, I'm here to give you some assistance or link you with the proper person if need be. So oftentimes people are truthful, especially when they are feeling a bit suicidal but don't really want to do that. So people can be very honest about it. If it's been something that they've been struggling with, they know the signs, they know how they're feeling, and they may have, may be on some medication or have been on medication in the past, so they will be open to it, to support also.
Yeah. Question for you. If you're, say, you're working and you happen to be at the shelter as an expert person, but say you're registered or something like that, somebody comes up to you screaming, hollering, using maybe some other type of language, how would you handle that?
But when people, I look to the back because one of this person who runs our shelter every day, she, this is almost a common occurrence. Janet's eating, she's in the back, and so I might have to bring her up here. But that's almost a common occurrence for us. We run in what we consider an emergency shelter for Cuyahoga County. We have about 160 ladies on average there every night. Over 50% of those ladies are mentally ill. And what we have to do if those situations occur, because we often have people who are unmedicated, who are in the shelter, we show extreme patience. You have to show extreme patience and support. If people are yelling and screaming, you do everything you can to go in be just the opposite. You want to be calm, you want to speak calmly to them, but firmly, and ask them in the most respectful tone to calm down and change their language. What is the problem? What can I do to help you? What's happening today? What's wrong? How can we help you?
Would switching off to a possibly another person be a help?
And if you become the target, yes. If you are, for some reason, maybe you look, it might be helpful to get another person because maybe you've done something or said something that triggers that. So, yes, that might be helpful to ask someone else to step in and assist. Or, for whatever reason, maybe you're just stressed out and you're unable to respond properly to bring that person down. So that would be the other reason why you might ask for some assistance from another party who's available.
Thank you.
Mm-hmm.
So what's the backup plan that say none of that works and that escalates to the point where they're getting physically violent? And you're the crisis team. I mean, if it goes beyond, do you have security? Do you have, I'm not somebody that can put somebody down if they're really hurting somebody else, but what's the plan?
Well, what we do with our shelter, our mobile crisis team is available to support us also. They come in and if necessary and assist. But yes, in times if someone really can't calm down, if it's beyond them showing any self-control, we actually do have security on site, and that is how we have to handle those. Well, our staff are not trained, like say in self-defense. We don't do seclusion or restraint. We don't do anything like that. We try to get out of the way. So, if someone becomes physical, we will, say block or punch or something and go in the other direction. So we have
people who have restraint if need be.
Right. We have security who can restrain if need be, and the most we would do is maybe hug the person or something, and if they grab someone, but that would be it.
Hurting themselves.
Yes. Right. Mm-hmm. But we don't do any physical restraint. even to keep them from hurting themselves. If they are tearing up the facility, as long as they're not hurting anyone else, we can't hold them.
Can you transfer them? Your place used to be known as the Spot, okay?
The Spot was our facility that we once had,
okay.
and it was for males.
Okay.
It was for men. We no longer have that. But yet we could, but we don't operate the Spot anymore. Just for consolidation with the county, we don't have funding for that. So.
Well, do you have a triage for people you let into the shelter, diagnostic categories?
We don't necessarily have, I guess to determine diagnostic categories, we don't have anything just for people coming into the shelter. Because our assumption when you come into the shelter is that you're just homeless and seeking services. So our assessment primarily is focused towards your housing needs. But as a part of that housing need, what are some barriers that are keeping you from having housing today? Do you have ongoing services with a mental health agency? Do you have any alcohol and drug addiction issues? Are you disabled in any way? So that's kind of how we triage those things. So, and then we link them to proper services.
And most people would be depressed if they lost their home.
Yes. You have an expectation that the people that are standing in front of you are going to be depressed. So you do have some expectation in situations of depression, which is why I was saying before, with major depression, it's lasting longer than, that adjustment period to your current circumstances. It goes beyond 2 weeks and just lingers into some, a point where it's dysfunctional, where you can't not function daily. And we actually have a lot of services that we coordinate with at the shelter, and sounds like Red Cross would be doing the same thing if there was a disaster. As I said earlier, our crisis team are also Red Cross trained for the mental health disaster services, so I know we would do that. We have mental health professionals come to our shelter every day to try to engage individuals, people who we identify who might need services, or maybe they even can talk, just notice some behaviors and they approach them that way. And we try to link with other services also.
I know you weren't talking about alcohol dependency or drugs, but if we're opening a shelter because of a widespread disaster, there's bound to be individuals entering a shelter with people who don't have those issues, who may start going through withdrawal from alcohol if they don't have access to it, or how do you deal with those issues in a shelter?
As long as I've been doing this, I guess I have never seen anyone go through withdrawals, but I know it actually occurs. And so in that instance, you have to get that person to the hospital. We cannot, in a shelter, you couldn't even address it because there's different medications that, that are needed. So there's medical attention that is needed. And I would hope in a disaster situation that they would have someone available to get someone, the medical staff available to address that. So I can actually say I've never seen it, but I know it has happened. Jan, what about you? You seen anyone?
Yeah, we've seen folks who are, either coming out of jail or not jail, I'm sorry, coming out of treatment, coming from somewhere, or just coming straight into the shelter, and they have to stay dry, and they have a real tough time, so they do need medical support.
Okay. So we would just that's the link with someone who provides medical support.
Ashland, do you have any questions?
Do you deploy with buckets of medicines, or, because you're talking about a fixed shelter, and in an emergency situation where you have to set up a mass shelter, and you have persons who, exhibit signs of schizophrenia and so forth, and can be a harm to others, how quickly can you deploy?
I wanted to say, at mental health services, we don't have medication. We don't, we prescribe medication because the clients are seeing our doctor. But the lady who presented before me, Megan, she was saying that American Red Cross was working to have limited access to medication, so limited supplies of medication.
If the person coming into your shelter knows what medication they're on, and if they have not brought medication with them or they're running out, Red Cross could probably try to help them access that. And I know, I think we've had this discussion a couple of years ago, that the state also has caches of medication. Might not be exactly what they're used to taking, but in a major disaster, we could get in touch with the state, and I think the ADAMHS board would know which connections to make with that to be able to at least bring those medications to the community and then have somebody who is qualified to dispense that medication.
That's what happened during Hurricane Katrina when we had people come over to Cleveland seeking assistance, and we had our mental health providers and all the volunteers were there to take care of them. If they did not have their medication, we were taking down the name of the medication if they knew it, which hopefully they did, and trying to connect them to what we call farm management services, which is seeing a psychiatrist or a licensed nurse that can prescribe temporary dosage for them until we link them to an ongoing permanent provider. Right. And we have several of the mental health providers do have central pharmacy, what we call central pharmacy services. They do have pharmacies with medication that the board will subsidize, so they can prescribe them, but they have to meet the client. They cannot go based on the client saying, let's say I'm there and I say, oh, well, I'm on this and this and that, and so they will give it to me. They will have to meet the client. So the role of the mental health providers during those shelters during Hurricane Katrina was very important because they did the linkage to make sure that everyone who needed assistance, whether they needed medication or therapy even, received it by connecting them to the agency that has central pharmacy and can provide the medication. If this is an ongoing issue that we always work with the Board of Health, the County Board of Health, and the state, and always ask them when you have pods, what they call pods, it stands for
Point of Dispensing.
Point of Dispensing. We keep telling them not just medications for diabetes and hypertension and those things, we also need to have psychotropic medication. So this is an ongoing debate.
Did that answer your question?
Not really, but I think that it's a serious issue, and I don't think that there's enough professionals to go around. Obviously, you would have a serious time delay, and with withdrawal symptoms for people without their meds. It's just I perceive it to be a significant issue.
And I think that's probably some of that is where planning comes in. How can we best do that? I think, encouraging people who are on medication to either bring medication with them or to have a list, hopefully from their provider, of what medications they're on, because then Red Cross has some avenues to go where they could possibly get prescriptions refilled, and that would certainly make it easier. So some of it comes with planning and making sure that people are bringing the right things to shelters with them. And sometimes that's not always possible, but that's one of the options.
And we do train our consumers who reside at group homes or residential places. We train them to have an emergency plan and always make sure you take your medication with you. Plus, if they're residing at a group home or a residential place, the group home operator or the manager of the residential place will make sure that that the medication is taken with them at least, for a period of time, for a few days or a week. So it's education as well as training.
Thank you. I have more questions. Does anybody else have questions here? Latonya, when you were talking about post-traumatic stress disorder, and we talked about that a natural disaster could lead to that, does it happen immediately, or might it happen later? So I guess, the question is, if the disaster happened today, if there was flooding or whatever, and you were getting people in, would you see those symptoms now, or would you see them in a week, or how long does it take to develop? And is there treatment for it?
It can manifest differently in individuals. So it could be an immediate reaction. It could be weeks later when someone realizes that they have not been getting any rest because they have nightmares every night. So some people, have different realizations about what's going on. For those who are seeking assistance, there's treatment. Depending on the symptoms, if there's anxiety, they can be given some anti-anxiety medication. So that's the one thing about mental illness is that most people respond to medical treatment. They respond to medications designed to address the symptoms. But with PTSD, counseling is also very, very helpful and is really needed when somebody is suffering from post-traumatic stress disorder. So support, medication, counseling. And that could be lengthy too. That could be short-term.